Hello, and welcome to Grand Round's COVID-19 edition, a place where cancer patients can get all of their questions answered by medical experts. But before we meet our panel today, we want to thank everyone on the front lines. Whether you are a doctor, a nurse, whether you are someone who cleans the hospital, whether you are someone who's preparing food for people at the hospital, we say thank you. And with that, I would like to introduce our two guests today. They are medical doctors, but of different areas of expertise. Dr. Mark Lewis and Dr. Mark Swanson. Doctors, please introduce yourselves.
Sure, Jonathan, nice to speak to you. So I'm Mark Lewis. I'm a medical oncologist. I practice in Salt Lake City, Utah, and my practice is largely dealing with cancers of the gut and also cancers affecting adolescents and young adults.
Thanks for having me. I'm Mark Swanson. I'm a head and neck cancer surgeon based out of Los Angeles at University of Southern California. So thanks for having me.
Thank you. I know how busy you are, so I really appreciate both of you to take this time. Dr. Lewis, you mentioned that one of your areas of expertise is working with young adults. There seems to be a narrative out there that this disease, COVID-19, is only impacting elderly people. And it's something that the young adults aren't really taking seriously. We see it with spring break, people not socially distancing. I was wondering if you could kind of explain why this is something that people of all ages should be taking seriously and why.
Sure. I'll actually just get right to the chase and say that I think it's an ethical responsibility that we all have to curb the spread of the virus. As you said, Jonathan, thankfully, the silver lining of this disease is it seems to leave young people, especially children, relatively unaffected. And I can speak with some expertise on this because my wife is a pediatrician in urgent care. And so she is not seeing, and I think this is borne out nationally and internationally, she's not seeing a lot of cases in kids. Now, in young adults, there have been some very tragic reports of patients, even normal people in their 20s and 30s, dying of very acute respiratory distress, which is obviously a huge concern for all of us. I would say two things. It just came out of Iceland that probably about half of the people carrying coronavirus in the adult population don't actually know that they have it. They're completely asymptomatic. And so one of the caveats I saw was don't socially distance because you're worried about getting the virus. Socially distance because you should assume you have it and you don't want to transmit it to other people. So that's the first part. And then the second part is specifically for this patient population that we're addressing. One of the really troubling early studies out of China, where of course a lot of the early work was done and the early alarms were raised, showed that for patients with cancer, the risk of serious effects from COVID-19 was probably 5-fold that of the general population. Now, the nuance there is that the median age of those patients was in their mid-60s, so not quite the adolescent young adult population that we're addressing. However, I think there's still a signal there that patients that are going through treatment that lowers the immune system are at heightened risk. So for everybody out there, again, you should be doing this to protect yourself, but I think by extension, you're also protecting everybody, literally everybody around you.
Thank you. Dr. Swanson.
Yeah, I agree with those points. Healthy young adults are in general at low risk of death from the disease, but that doesn't mean they're not going to get significant disease. A big proportion of the patients who are hospitalized fall into that younger category. And we don't know the long-term effects from that yet. There could be permanent restrictive lung disease, which can affect you lifelong. So that's one issue. Two is the issue of being a vector to spread to other people. If we can stop one person from getting it, who might transfer it to 4 people, who might transfer it to 16 people, who might transfer it on, we can really limit the spread of disease and decrease our hospital burden. And if the hospital's burdened and you're a young, healthy adult who gets in an accident or has an appendicitis or whatever, all of a sudden the hospitals are overwhelmed. And even though you don't have coronavirus, you're not getting the adequate care you need because the hospital doesn't have the resources. So it's important just for everybody to stay home so that we can decrease our burden on the hospital system.
Thank you. Hospital burden kind of brings up my next question. We're very lucky today to have both cancer doctors, but one is a surgical oncologist and one is a medical oncologist. Both are experts in their particular field and different parts of the body for that matter. What is considered elective at this time for a cancer patient and what isn't? For that matter, for any patient.
So we're trying, I feel like our cancer patients are caught in the middle of this. They don't necessarily have coronavirus, but all of a sudden they're having limited access to the care they need. So we have to figure out a way to deliver care that's safe for them. So we've been trying to limit how many times they have to come into the hospital for non-essential appointments and moving some of those patients to telemed visits where they can do it from the safety of their own home. And that's a lot for the protection of the hospital staff and also for themselves. Cancer patients are increased risk for coronavirus. So the more we can keep them at home and away from having risk of exposure, the better. So patients with routine follow-up visits, go over scans, stuff that you can do over telephone or video calls as we're shifting those patients towards that. The difficult part is our surgical patients. Surgeries require a lot of medical resources, sometimes ICU beds, a lot of protective equipment that hospital providers need potentially to care for COVID and coronavirus patients. So deciding who is urgent enough for surgery is being a bit of a challenge. So my general rule of thumb is if it can be delayed more than 2 or 3 weeks, we should delay it. If it would affect their cancer outcomes, then we go ahead and do it. Right now in Los Angeles, our hospitals aren't saturated, so we have the capacity to treat our patients without any delay. But as we move forward, we're kind of constantly readjusting. And one strategy we're doing is potentially changing our therapy. So if we can do maybe outpatient chemotherapy first before surgery to push them past this COVID outbreak so that we can reduce their risk and reduce the burden on the hospital system, is something that we're thinking about.
Wonderful. Dr. Lewis, what's your thoughts on the matter?
Yeah, it's fascinating to hear a colleague from another discipline, how they break it down. I actually think quite similarly, even though my practice is different than Dr. Swanson. So the way I think about my patients right now, Jonathan, is I break them into 3 groups.
Okay.
The first are patients that are thankfully through all of their treatment and are in the survivorship phase, where any visit we'd be having would largely hopefully be routine follow-up. And just like Dr. Swanson said, I'm doing most, if not all of those visits through the exact same mechanism you're using to talk to me right now. And it's been very fulfilling. And I actually kind of wonder, once the dust settles and all this, if this won't become the new mode of communication for those kind of visits. I think it's very patient-centric. I think it's very modern. And hopefully we'll see some, at least, shift to doing visits that way. The second group of patients I have might actually be the most clear-cut. These are patients with really aggressive metastatic disease where, in my judgment, the threat of their cancer outweighs the threat from the virus. And so in those people—
Could you explain what metastatic means?
Yeah, sorry. So cancer that has spread beyond the organ where it started to other parts of the body. So for instance, I have a lot, unfortunately, of patients with pancreatic cancer, which is a very aggressive malignancy to start with. And when it spreads to the liver, unfortunately, patients' life expectancy is very, very limited indeed, Jonathan. So as an example, I've got patients right now who are on treatment, have a very worrisome amount of cancer in their liver. And if I were to withhold the chemotherapy, it is quite likely that they would die of liver failure. And thus, it's risky, I'll grant you that, but we have to sort of proceed with chemotherapy, understanding and communicating to the patient all the risks of that. I sometimes have to drop the dose of a drug, so the impact of the chemo on the immune system isn't quite as heavy. Sometimes I've had to change the schedule of dosing. But those are the patients where, again, they're sort of between a rock and a hard place. On the one side, they've got the cancer. On the other side, they've got the threat of this viral pandemic. And it's tricky, but in a lot of those folks, it ends up where if we neglected their cancer treatment, they would actually die fairly quickly of their malignancy. And so we proceed carefully in those patients. And then finally, and this is probably, I think, the trickiest group, we have patients in what are called the adjuvant space.
Can you explain that?
again, in my practice, let's say you've had a cancer in your colon that has already been removed surgically by a surgeon. And now we're considering chemotherapy to reduce the risk of that coming back. Those are very nuanced conversations to be having at this point in time. Typically, for the chemotherapy to be effective in reducing the return of a cancer, you have to start the chemo within 2 and certainly no more than 3 months after the operation that removed it. And really what we're doing here is destroying microscopic seeds that we can't see, but we suspect might be remnant after the surgery. And that's probably the hardest population that I have to deal with right now. Patients themselves aren't difficult, but the conversations are very, very challenging indeed. There again, we have some latitude, I hope, to make the chemo less intense. Not every chemo, I should stress, actually reduces the immune system. I think that's a common myth. Chemo is just an umbrella term, just like antibiotics is an umbrella term. So not all chemo is created equal. Not all chemo reduces your immune defenses, but it really is a case-by-case judgment and a case-by-case prescription of the chemotherapy, and then watching closely to see what impact it actually has on immunity.
Thank you. I know how valuable your time is, so we don't want to take more, but we do have a fan question. Do I need to revisit my advanced care plan documents, even though my cancer is early stage and I should be curable?
Wow. So I want to stress, and Dr. Swanson was talking about this earlier. So again, most of the people affected by COVID-19 being the actual disease, the condition, not the virus itself, most of the people affected by COVID-19 will either have no symptoms at all or will have mild symptoms. The people that we're worried about are the very concerning minority where they get admitted to the hospital. And what we've been seeing is a pattern where people can go from breathing okay to having a real struggle breathing to almost immediately needing a ventilator. So in that,
Dr. Lewis, how quickly does that happen?
the speed of the evolution is quite concerning. And in that scenario, we have to insert a breathing tube that allows them to have assisted ventilation. So a couple of things about that. A lot of our doctors have actually erred on the side of intubating sooner rather than later for 2 reasons. 1, obviously you want to rescue the patient in time. 2, the main risk to healthcare workers, and I know I'm getting off topic, I'll come back to your question, is aerosolization. So that the virus can be spread in a very, very fine mist. I know this is kind of gross. When the tube is going down the throat, putting the doctors and the healthcare workers, the nurses and the respiratory therapists at very, very heightened risk that they're going to have transmission to them. So when you go on one of these machines, you cannot talk. And I know this is really I think the core of your question is that the reason it's important to write down your wishes in advance is you will not be able to communicate in any verbal fashion when you're on a ventilator. And it's really, really important that you have pre-specified what you want in writing. At the very least, you should designate a surrogate, someone close to you who you trust to make decisions for you. But ideally, to unburden them, everything would be communicated in writing. So back to the actual question. The good news, and there is good news about COVID-19, is that some people are getting off the ventilator. So just because you go on the ventilator, if we can support you for a period of time, you can get off of it. Now, this is very anecdotal. In my own hospital last week, 5 people were intubated, so went on a ventilator, and 4 of them are now off. Okay. Now, unfortunately, the numbers nationally, internationally are not quite that good. I've heard some very sobering statistics of up to 70% of people going on the ventilator not coming off the ventilator. So, early days here where I practice, and maybe things will get worse. But the long answer, of course, to the question is, I don't think this should necessarily change your advanced directive. I would go into this hoping that this would be temporary reliance on a ventilator and assisted breathing. But Dr. Swanson may have other feelings about that.
No, I agree with a lot of the points you're saying. These are difficult conversations to have, and I think the conversation starts at home. You talking with your spouse, talking with your children, talking with your family about what you want. You always put family members in a difficult position when you're in the hospital and you can't make decisions for you, and now you have your spouse or your children making decisions. And if you've never talked to them about what you want, they're in a tough spot. So having these conversations with your family is important, and having it in writing makes it even easier. It takes that burden of the decision away from your family members. And this isn't something that is important just for cancer patients or just important now. This is something that's important for everybody all the time. You should always have a plan for if you can't make decisions for yourself and how to do it. So I think now it just brings a little bit more of the urgency to it about having these talks.
Wonderful point. I think what I'm taking away is having someone on your side, having an advocate for you when you can't speak for yourself. And I think that's true for any cancer experience, but even more so given this current climate. I cannot thank you enough for your time. I think this has been very insightful. Please stay healthy, stay socially distant, but keep doing wonderful work, and I look forward to speaking to you soon.
Yeah. The best advice I got so far is keep physical distance, but not social distance. So make sure you keep in touch via Zoom and via FaceTime and text message and email. So keep your social contacts up. Just stay physically distant.
Absolutely correct. I think the most important thing to do right now, even though you may not have a medical degree or a degree to be a nurse or a pharmacist, you can call a friend. You can call, and just say, "What's going on? How are you?" And let them know that you're thinking of them. I think that this social distancing is new for all of us and hard. It's very challenging. So give your friend a call and let them know you're thinking of them.